Good evening. I'm Dr. Jackie Weisbein, and welcome to the Pacific Spine and Pain Society. This is our sponsored webinar from our lovely sponsors, Abbott and Reactivate by Mainstay. I'm very excited to introduce my colleague, I'm sorry, Ryan, I was going to upgrade you, but there's no
Take
upgrade
it.
needed. Ryan Hill Falkenthal is a PA that practices at Nova Spine in Arizona. He's the lead PA there. And so Ryan and I are going to be spending some time talking about, um, the principles of patient selection across Abbott's chronic pain portfolio. Ryan, can you give us a little background about yourself? Because I know you've done a lot of training, you have a master's. Talk about yourself a little bit.
Absolutely. So I've been doing pain for a few years now. Previously after graduating PA school, I went to the spine route. So I was doing spine trauma for a couple of years, which kind of came into pain just really nicely with the MRIs and low back pain, spinal cord stimulation. Obviously, we put those in as a spine surgery team, which was nice. It was a nice transition and a pretty easy transition coming from 80 to 100-hour weeks to these beautiful 4 days, 4 tens. And then prior to that, I served 5 years in the Navy. I was a medic in the United States Navy. So it's all kind of transitions in the medical world, which has been kind of nice.
Well, thank you for your service and thank you for
Absolutely.
being available this evening so that you and I could have this discussion. So Lincoln, thanks. I think I have control now. So first, this is our first APP webinar of this series. We have another one coming up. And hopefully those of you who are joining us are also able to join us at our upcoming PSPS annual meeting at the Pendry in Newport Beach. But first, let's talk a little bit about Abbott's chronic pain portfolio and some of the options that we've got here. So with that, again, support is provided by Abbott, and we are presenting on behalf of Abbott. And this is all stuff that is applicable with FDA guidelines, and I'll let you read that because no one likes being read those things. And again, this is going to be webinar 2, patient selection, our Abbott portfolio and case studies. And then again, this is also supported by Reactivate as well. So principles of patient selection and the expanding indication. So one of the things that is really amazing is that I've worked for a long time in this pain space. I don't want to say how long because I have so much Botox in my face that I look young. But the truth of the matter is that spinal cord stimulation, neuromodulation has changed dramatically. And when I say change dramatically, I think about things like when I first trained, there was only one device that had any kind of conditional MR, and that was for head only. And then over the years, now it's evolved to full body for most of these companies. And additionally, we previously had only tonic stimulation, and we've seen in the past 10, 15 years that there has been a huge focus on waveforms. So when we think about spinal cord stimulation, there are a lot of things to consider, right? Have patients already failed the conservative treatments? Are we ruling out that there's not some other supratentorial thing that might be causing them to have pain? Is the pain primary neuropathic? So I actually did a trial on a patient last week who was a diabetic, and on the morning of her trial, she was having this acute low back, lower extremity pain. It may kind of sound a little ridiculous, but even though we got it mapped and she did great with the trial, that one area of her pain was not really covered. And because it was kind of acute, she wasn't really stressed about it. But believe it or not, when the trial ended, I examined her and it was like very obvious sacroiliac joint pain. We did a sacroiliac joint injection for her yesterday, the royal we, and she was like, I'm 100% better from that pain. So, understanding, is it truly neuropathic pain? Is it mechanical pain? And understanding how to kind of figure out the difference because, we also want to make sure that we're not missing something, right? So, you can stim something and they may benefit, but also making sure that this isn't a patient that needs some kind of surgical correction of an instability or things like that. So again, if you find out a patient has a number of different things going on, which most of them do when they come with their MRIs, I tell them the MRI is just a tool that acts in concert with the history and the physical exam. And so we want to make sure, is a pain I'm so sorry, my Great Dane is going to pop her head in, but is the pain mechanical or neuropathic? Do they have any issues that might prevent them from being able to recognize if they're having pain relief? Is there anything that might preclude them from being a good candidate? Like, do they have some kind of secondary gain? Are there any untreated psychological comorbidities, or are they, for whatever reason, medically frail enough that they won't tolerate the implant? Um, so I tried to move, there it goes. So one of the things that has happened, again, are the applications have grown over the years. When we've been using spinal cord stimulation, it was for the primary indications that the FDA approved it for, which was failed back surgery syndrome or post-laminectomy syndrome or complex regional pain syndrome. And because typically spinal cord stimulation, if you read a lot of the guidelines, is for chronic pain of the trunk and limbs, right? We've recently had new indications because of studies that have been conducted nationally and internationally for both diabetic peripheral neuropathy of the lower extremities as well as non-surgical low back pain. I was fortunate to participate in the distinct trial, and it's really amazing to see these patients who had no options for anything else have a durable therapy option. And because of that, Burst DR is now FDA approved for non-surgical back pain. This was the largest study with the largest cohort. And basically, I don't need to tell you guys, people that are on this webinar, that low back pain is something that is prevalent in our communities, right? It doesn't matter if you live in California or Arizona. People have low back pain, and there's a good cohort of them, and some of them are more stoic than others. But Distinct was a landmark study because it was, again, the largest cohort of patients. And of those patients implanted, a lot of them had a significant improvement in their back pain compared to those who only received conservative medical treatment. And funny, one of the things about this study too is that patients who were randomized into the conservative medical treatment group were able to leave that group and opt for spinal cord stimulation if they weren't doing well with it. But what you can see is that 91% of these patients that were implanted with Burst DR had a significant reduction in their numerical rating scale or their ODI. These patients were having improvements in their previously perceived disabilities in their life, and also a significant improvement in their mindset, right? With an 80, almost 87% reduction in their catastrophization. So things that we're going to kind of pose some questions, and those of you on, please kind of think about what you'd like to talk about towards the end of this webinar. But there's such a wide diagnosis with these patients. How do you consider these patients to be a good candidate for spinal cord stimulation? And then how do you also convince spine surgeons that these patients may be they may benefit from spinal cord stimulation? Now, I'm going to let our group, our cohort, think about that. But Ryan, I'm going to put you on the spot. So you said you worked in surgery before. So, sometimes it can be difficult to convince some of our spine surgery colleagues that maybe a non-invasive treatment like spinal cord stimulation or something that they get to test out might be beneficial. But what are the things that you're kind of thinking about since you've kind of seen both ends of this scale?
Absolutely. That's a great question, right? Because, you never want to piss off your spine surgeons. That's a referral base. There's obviously, kind of political side of things that happen. But, you know, I would just try to convince, spine surgeons into at least allowing the patient to trial, right? If God forbid, that they want to do, like a L2 to S1 fusion, huge whack, laminectomy fusion, multiple screws, cages, you know, maybe this patient could benefit significantly from a spinal cord stimulator, or they had that laminectomy already and the surgeon wants to go back in and do that L2 to S1 fusion or what have you. Maybe this patient can benefit from a trial. Let's allow me to do a 5-day trial, 7-day trial. I'll send the patient back to you. If that patient comes back to you and is like, what, that trial was not worth it, I want to do this huge surgery, have at it. But if that patient comes back and they're like, I felt great. I can do this minimally invasive surgery and I can feel better for essentially the rest of my life. And guess what? God forbid, 5, 10 years down the road, the patient needs surgery, you can still do it.
Absolutely. I love that. I mean, I think that's a really great way of navigating it. It's funny too, you never want to bite the hand that feeds you. I'm in an orthopedic group. One of my partners is a spine surgeon. Yesterday, he texted me. He said, I'm seeing a patient right now. She had a previous laminectomy. I don't have any more surgery to offer her. I think she'd be a great stim patient. I saw her today and I was like, yeah, you might be a great stim patient. You also have some mechanical pain that will likely not respond to stimulation. So we'll have to do some other stuff for that too. But making sure also patients understand this is not a panacea, right? Nothing is. And so, all of these things can work in concert together. But I love the way that, you navigate it with like this is something that they can try. Now, this has been an amazing thing for my community as well. I reached out to an endocrinology practice, the only one in town, and I shared with them the results of this information. I mean, we know that patients with diabetic peripheral neuropathy, any kind of neuropathy, whether it's from, like chemotherapy or radiation, things like that, it can be super bothersome for our patients. But patients with diabetic peripheral neuropathy, I can't tell you how many of them come in and talk to me about how, this constant burning paresthesias in their feet. And so what we've seen is that through Abbott's recent trial, they were able to obtain FDA approval for the treatment of pain associated with diabetic peripheral neuropathy. And 70% of those patients responded to SCS therapy. So again, one of the trials that I performed this past week was a patient with diabetic peripheral neuropathy, and she was just amazed. And interestingly, when we pulled her leads on Monday, I saw her on Tuesday for a procedure. She was still experiencing some carryover effect from the burst trial and still reporting a significant improvement. Now, I told her not to get used to it. It's likely going to come back before her implant, but the reality is that 53% of the patients had an average reduction in their significant pain, and that's in comparison to the patients who have been medically managed in this diabetic group, who are only using the neuropathic agents that we have. But the truth of the matter is that some of these patients also end up on opiates or other types of medication as well. And the study actually was able to demonstrate that patients were able to decrease their medication as well. So when I think about these patients, these are patients who have developed peripheral issues like neuropathic changes. A lot of these patients also have some vascular issues too, because when we think about our diabetic patients, right, they're having not just an issue with their nerves, but they're actually also having issues with their vasculature. And we know that, burst can help with some of that pain associated with their DPN. Typically hemoglobin less than 10. I was actually talking on another webinar yesterday and we were talking about hemoglobin A1C and Dr. Hagedorn and a couple other people published a paper that really the hemoglobin A1C as an isolated thing is not necessarily something that would hold someone from having a procedure. And it didn't show that that was enough to be a significant risk. I don't actually check hemoglobin A1Cs, but I do check like a CMP where they're fasting beforehand. And obviously if like their sugar is like 8 billion, I'm like, okay, we got to get some stuff under control before we move forward with this. But you want to have them that have significant pain that's affecting their quality of life. And then they're in good enough health that they can undergo a medical procedure. So I would say, Ryan, when you think about your patient base, do you have a good cohort of your chronic pain patients that you guys see in your practice that also have diabetes, or is everyone in Arizona healthier than Napa? And I am so sorry, that is my Great Dane. Yeah,
Well,
just for 1 second right there.
yeah, there we go. I will say, I have not seen a blood glucose of 8 billion, fortunately. Um,
You didn't
but,
practice in Virginia.
yeah. But yes, I mean, on average, most of our patients, tend to have diabetes. It just comes with the territory. So yeah, we have a ton of patients that have DPN, and really, when it comes to your guys' practice, it really comes down to kind of marketing, right? You talked about, going to your endocrinologist, the one you have in Napa, really going out to these endocrinologists, these people that, these doctors that see this DPN every single day, constantly, multiple patients, and they're not doing well. They're not doing well on medications, and offering this option, right, stimulation for DPN. And once again, it kind of goes back to what I said about spine surgeries. Like, why don't we just give this a shot? We're not going to steal your patient. We'll we'll try it, do a trial. If this patient does well, we'll send, we'll perm them, send them right back. You're still managing their diabetes. You still keep them on certain medications if needed. It really comes down to like getting out and marketing because I'm sure most of these endocrinologists don't know about this.
Yeah, or podiatrists as well. This is a
Dietitians as
really
well.
great untapped location. I also found that a lot of these patients, because they have diabetes, they actually never get a real spine workup. And so when I was
Yeah.
meeting with this endocrinology group, and the guy who is the PA in this group, he's awesome, and he's like super into referring me patients. And, a lot of them have never had any kind of workup. And then I start working them up. And it's not just that they have, DMP, and they also have, spinal stenosis that's severe. It's like nobody ever looked. And a lot of times what happens is that these patients have pain and they're like, oh, it's because you have diabetes, and no one really works it up. So, sometimes it's just an entryway for these patients to also get back into a continuum of care where it's not just focused on their endocrinology stuff. So, really, really great tips there. So with that, Ryan, I'm gonna quickly go through the those reference slides. I'm gonna hand it over to you, and I think we'll switch the control to you so that you can move it
Perfect.
going.
But for from an APP standpoint, right? This is our bread and butter. Okay, patient selection. You really want to be well versed in patient selection. I know from my practice, I'm sure from multiple practices, right? The doctor may see a new patient. Then our goal is to keep your doctors in the OR doing injections. As an APP, you're seeing these patients month after month after month, or however often you see them. So, being able to have these conversations with patients and educating them and having the background to educate patients on what dorsal root ganglion stimulation is, or spinal cord stimulation, or anything from a pain management standpoint is truly should be our bread and butter. And then just understand that these patients are in your practice now. We see these patients every single day, whether it be a conversation tomorrow with a patient that isn't feeling great about a spinal cord stimulator. Most patients are like, oh, I don't want to, they already had spine surgery, I don't want another surgery. Educating them on how minimally invasive this is, just trying a trial, do this for 5 days. If this doesn't work, okay, we go back to the drawing board, get back to it. And then also just, kind of setting expectations, right? Like Dr. Wiseman has said, a spinal cord stimulator is likely not going to get rid of 100% of a patient's pain. There's multiple different issues that most of our patients have, whether it be neuropathic or nociceptive pain. But, really, like this slide said, all pain is not equal, right? Two different pains that we can talk about, one being focal pain and one being broad pain. When it comes to focal pain, kind of, isolated pain, it's focused normally on one body part. The patient may have had like a knee replacement, and they're still having this focal knee pain after years. They've gone back to ortho, and of course, ortho has taken x-rays, and they're like, my implant's perfect. I'm not going to do another revision, go back to pain management, talk to them about, nerve blocks, what have you. Or they had ankle surgeries. And, the challenges of this is that pain can be very difficult to treat. It's, the inability to capture that one focal pain area can be difficult. And that's where stimulation can play a huge role. Same with broad pain. Okay. So, that's kind of the wide overall body pain, that low back pain diffusely through the legs. We see that all the time in our practices. These patients already had a laminectomy, fusion, and really these patients are difficult to treat because we can't just treat this one pain with an epidural, or we do an RFA and help some of their back pain, but there's this diffuse leg pain that's not changed with an epidural or an SI joint injection. And you've kind of ruled all these things out. Stimulation is a great next candidate. So, choosing the right therapy, is important. And when we talk about focal pain versus broad pain, we kind of lean towards DRG, so dorsal root ganglion stimulation. And at the end of this this talk, we'll have a really good picture of some really good placement of DRG. And that's where we kind of talk about CRPS or causalgia. So CRPS, and we'll get into a little bit more specifics about CRPS. But if a patient has CRPS, like I said, with the knee pain post total knee, or say they had some type of car accident where their ankle got crushed and they went through multiple ankle surgeries and they're still having this, top of the foot pain or lateral ankle pain, DRG can be a great candidate. And then when we talk about a broad pain, that's where we kind of lean towards spinal cord stimulation, whether it be post laminectomy syndrome, right? The patient already had a laminectomy, already had spine surgery. And one, they're still having this diffuse nerve pain, and kind of what I give the example on post laminectomy and why these patients still have pain. It's like that nerve was crushed, right? So for however long that nerve was crushed, right? If you crinkle a piece of paper and you open that back up, well, that piece of paper is still going to be crinkled just a little bit. So that nerve never really recovers. The patients still have that pain down their leg. And then just like Dr. Wiseman talked about with diabetic peripheral neuropathy, also a great stimulator candidate. So CRPS. So CRPS can be very difficult. What I would tell you is get with your Abbott reps now, get with them tomorrow, and have them print out or have them type out the Budapest criteria, go online and type out the Budapest criteria that you can just slap on the wall or take into every room, and then you have that. Because when it comes to, at least in my experience, when it comes to CRPS and trying to get DRG approved, it can be very difficult if the proper documentation is not done, and that includes the update to history HPI section as well as the exam. So CRPS characterized by extreme pain out of proportion. Sorry about that. Dog's throwing toys around. Of proportion to the original injury with evidence of allodynia or hyperalgesia. And we'll talk about what that is as well on the next slide. Then you have CRPS type 2, or also called causalgia. So severe pain due to an injury to a peripheral nerve, can be traumatic or surgical. So I have a great DRG candidate, which we actually just ordered today. She has had, I believe, 3 knee surgeries off the top of my head. And I think after they tried manipulation under anesthesia, she ended up with a nerve injury. So she has this very severe pain on the lateral side of her leg. And she's a fantastic DRG candidate. It's just about getting it approved, which can be the difficult part. So here's that Budapest criteria. This is what I would tell you guys to print, type out, put in your room, because this is where documentation comes a major role. And then just the physical exam in general. So Budapest criteria, this, you have to have this for CRPS type. So the patient has continuing pain, which is disproportionate to the event, okay? At least one, the patient has one sign in 2 or more categories, okay? And then they also report one symptom, okay? So subjective and objective. So as a provider, from an objective standpoint, you need to be able to produce or see 2 of the bottom criteria. So whether that be sensory, right? So allodynia, so really, kind of severe pain or temperature sensation to light touch, as well as to pinprick with hyperalgesia. And then you can also, motor, pretty simple from a objective standpoint, right? So decreased range of motion and or weakness, okay? And then oftentimes these patients will actually lack the hair. So they'll kind of lose the hair in that area of that CRPS. But at the same time, these patients need to report one of these symptoms in one of the 3 categories. So either they notice the decreased range of motion, they notice the temperature sensation changes or asymmetry from one leg to another, or just on the same leg, color changes, etc. Once again, I would tell you guys just to print this out because this is a difficult chart to remember. And then also at the same time, I would tell you guys to print this out. So this is the dermatomal overview for DRG. Okay, so this is basically letting you know you can look at this chart and it's going to tell you exactly what dermatome you should be hitting or what nerve root you should be hitting from a dorsal root ganglion stimulation standpoint. So, for example, if you look at knee, right, on average, you would stimulate L3. You can also stimulate L4, but let's say if they have maybe bilateral knee replacements, continued bilateral knee pain, bilateral L3 DRG would be a great move. And at the end, you also see that a case study on that. And then the references, and we'll throw it back to Dr. Wiseman.
Thank you so much. That was really great. And I love how you encourage people to print that out. Our EMR actually has a thing where I can just click Budapest criteria and then just click the boxes and add it into my notes. So I try and add it in whether the patients
That
have
would be great.
CRPS type 1 or 2, right? Because I want to make sure. And, a lot of times I'll type in caps lock, like no other diagnosis is supported based on these clinical exam findings, because it can be really challenging to advocate for our patients. The beautiful thing about the Abbott portfolio, though, is to Ryan's talk, is that there are a number of different systems for each patient. We have the Proclaim XR and Proclaim Plus, which are the non-rechargeable. And then we have the Eterna, which recently came out. I like to think of it as the rechargeable, non-rechargeable. When we look at the explant data for spinal cord stimulation, obviously the number one reason that patients get their device explanted is because they fail the therapy for whatever reason. But what we see is that patients with non-rechargeable batteries had a lot longer use of their system compared to those recharging. Because imagine if your device isn't working and you have to recharge every day or 3 or 4 times a week, it's going to become very burdensome. Whereas if your recharge burden is much lower and you have a durable therapy like Burst DR, you can absolutely have a really long life with this beautiful battery. And what's also amazing about it too is now with the advent of Flex Burst, patients with that have multifocal pain. So even if those are patients who may have, like back and then one leg or one part of their foot, you can use different programs to blend them together. Then we have the Proclaim DRG as well as the Ionic RF generator. So, the truth of the matter is Abbott's portfolio has a ton of options for your patients and to ensure that you're taking care of them. Too bad that RFA for the SI joint has no longer been covered, because they also had a Simplicity probe, which was amazing for SI joint radio frequency. But when we think about it, the reality is this is why is this such a beautiful portfolio? It's because it actually uses Burst DR. And what we've seen with Burst DR is that it has the ability to affect the pathways in the brain, both the lateral and medial pathways. And we see this on functional MRI. And what we know is that these two things, right, the pain and the suffering, minus inhibition equals global pain. And that really affects the way people perceive their life. Today, I had a long talk with someone about spinal cord stimulation and about quality of life, right? And, if that perceived suffering matched with that pain, it really affects people. And so when we use Burst DR compared to tonic firing of neurons, what we see is that with this clustered burst firing of neurons, what happens is there's this plateau of calcium depolarization, and then there's this period of dormancy. And during that period of dormancy, on the the neuromonitoring, we're able to see that, there's actually an action potential generator as opposed to the tonic stimulation or high frequency when we don't see that after that dormancy. And again, on functional MRI, we're able to see that there is alteration in patients' brains with regards to their emotional perception of pain, which I think is really important, right? Because, pain is not a static thing, it's dynamic, and it affects our ability to interact with our loved ones. So on that note, Ryan, I'm going to put you back on the spot. I kind of, talked briefly about the burst waveform, burst DR. So sometimes patients come in and they're like, I saw this other practice, and they said that they do burst, but not with Abbott. So are all burst waveforms the same? And how do you describe burst DR to your patients?
Oh gosh, put me on the spot there.
Sorry. Do you want me to go first? I'll tell you how I
I
describe it
would
to my
love you to
patients.
go first because
Okay.
I just hand it over to the reps usually.
Oh God. Okay. Well, so the thing about it is, not all bursts are the same. And so there's some companies that put out that they can do microbursts or things like that. And really what those are just kind of rapid stack charges of tonic stimulation. With burst DR, what we see is actually a stack charge. So, if I really want to get esoteric and the time is not a limiting factor, I'll tell patients, we're a meat-coated skeleton piloted by a jello mold, and at the cellular level, there's all these little ions and they're being pushed through the cell wall, and that's creating power. And somehow we're able to think and move and do stuff. But I don't really get that granular with them. And I kind of tell them that our body is basically harnessing electricity. And so when we understand that everything we do is some kind of, electrical current, if we could mimic our body's natural electrical current and kind of help it perceive things that are misfiring as now being closer or back to normal, then that's a really great way of using electricity to help patients heal. And it's not anything like TENS unit, right? Because a TENS unit you have to feel, whereas this one is paresthesia free. So that's a little bit of my spiel. But when you talk to patients about, non-paresthesia stim, Ryan, I mean, obviously it's easy to hand it off to Waylon. He's such a talented rep. But the truth of the matter is, I'm sure at some point the patients want to have a discussion with you about it. So what do you tell them about? I mean, the easy idea of like a pacemaker is simple, but how do you
Yeah.
tell them about a pacemaker for their spine?
So really what I compare it to, and I try to just for one, I try to explain just how minimally invasive it is because whenever you say, spinal cord or a surgery, they think massive spine surgery, right? They think of some surgery they may or may not already have had. It took a extremely long recovery, very painful, likely obviously didn't recover all that well because they're still in this pain. So I try to explain just how minimally invasive it is and just how simple the trial can be. I try to explain the trial before the perm. I just basically we're just poking those leads through your skin. We're gonna move it up to the middle of your thoracic spine, and we're gonna stimulate that spine, and we're gonna try to change that sensory perception back to your brain of that pain. We're not gonna change any of your ability to walk, etc., motor. We're just gonna change that sensory perception back to your brain of your pain. And then if that goes well, we can do a very small 2-inch incision where we don't even go below the muscle, and a small 2-inch incision on one of your flanks where we implant a battery. You have some small precautions for about 6 weeks and you recover quite nicely. And then you can work with the rep and get that stimulation, find that stimulation that you had during the trial for hopefully the rest of your life. We
I
kind
love
of
that.
just explain minimally invasiveness to what SES can be or DRG for that matter.
So I got to ask one more question. Hopefully,
Yeah.
Waylon, it doesn't cry because I mean, I'm sure Waylon doesn't want to hear about your experience with other systems. But
Oh,
in a large practice, I'm sure you've seen patients who either you've inherited or they've been implanted in your practice with other devices. Do you notice any difference with your patients who have been implanted with burst DR stimulation compared to some of the other products on the market?
absolutely. Absolutely. There are certain products out there that have a high explant rate, and we tend to unfortunately explant those and either retrial or reimplant with Abbott, and they do significantly better. They truly do. Um, and then one of just from one of the other complaints that patients tend to have is how big the battery is. Right? So just having the ability to implant Eterna, as long as a patient is okay with a rechargeable battery. Obviously, if they want a non-rechargeable, it is a larger battery cell. Um, but Eterna is so small, you won't even know it's in there. I mean, when we implant those things, it takes 2 seconds to make that pocket. It's amazing.
It is. So, over the last year with FlexBurst 360, this is something that I think is really beautiful because a lot of our patients have multi-site pain, and prior to the advent of FlexBurst 360, what would happen is that patients would have, multiple programs, right? So they'd have like a program that was more for their back and this part, but they might not get their foot. And now with FlexBurst 360, we're able to turn on different electrodes at the same time without them requiring any higher use of energy. It is a really amazing and unique thing that's customizable for the patients. And, it really can help patients who have complex pain, not just of one area, but multifocal area. And again, without increasing the energy usage as well. So, back to your point of the non-rechargeable. So we still have the Proclaim Plus. Proclaim Plus is a recharge-free device. It is full body MR conditional with upgradable technology. When we talk about the dosing, we talk about, how long there is that period of dormancy where we're not using that burst, right? And when we look at the BOSS study and the Boulder study, what we were able to see is that patients were able to have this device, you know, in that latent period from burst, so that burst, DR charge would go, and then in that dormancy it could be off for 30 seconds, 60 seconds, a minute, 3 minutes, 6 minutes. And the longer that they can tolerate it being off and still having adequate pain relief, obviously that would give these patients longer battery life. Now some of these patients don't do as well, because again, everybody's pain is unique and everybody's activity is unique. And so Abbott created one of the smallest footprints on the market with this, like I said, it's kind of the only rechargeable non-recharge battery, I guess, because the frequency of recharge in theory with using some of the burst settings might be that they only really have to recharge 5 times a year. And for good measure, because they don't feel any paresthesia for the most part, I just tell my patients to sit down for 30 minutes, watch their favorite TV show once a month, and charge it just to get it out of the way so they never have to worry. Again, this allows for patients to use MyPath, and we can do remote programming with this. For me in Northern California, I have patients that come from Tahoe and Oregon and all over. So having the ability to remotely program those patients without them having to drive, 4 to 6 hours to get here is a really amazing thing as well. And the extend technology, so what that means is that basically the Eterna battery is a Bluetooth battery, but it's not constantly searching for something to connect to. And so what that means is that it doesn't use like or waste energy just kind of going something trying to talk to me, something trying to talk to me. So it really only kind of activates once you connect to the device directly. And so that is one way that it saves energy. And the other way is by using the low energy burst DR stimulation waveform. And so again, back to what I was talking about, depending on how those patients are using their burst DR, they might only need to charge 5 times a year. So Ryan, with the advent of the Eterna and FlexBurst, I mean, you talked a lot about Eterna and how your patients are doing and how quick it is to make a pocket and things like that. But have you been utilizing the FlexBurst 360 since its advent to the market? And have you seen any changes with that?
I mean, we have been using it. I mean, we have kind of our practice has been on a little bit of a lull. We've had some surgery center issues, so we've kind of for a little while, which we're actually tomorrow. Very excited. So we've kind of had a lull in that type of implantation. But overall, I think Eterna has just been the biggest game changer, just from a patient comfort standpoint. Truly, battery site comfort. I don't think you can get to.
Yeah. It's true that, the battery site is, a really big deal. I mean, when
Mhm.
patients get site pain, and then, like I said, I have had patients who, we can get really good low back coverage, but then those same electrodes may not, even with like widening the pulse width, actually get coverage to their toe as much as they want. But anyhow, that's a great segue so as to get to the case presentation. So we have a little bit of time to get there. So Ryan, I'm going to let you take over these case studies because there are some
Perfect.
interesting ones. And I don't know if we have the ability to do a poll, but we could put this out there and see what people think. If not, we can just, if you have a chat box access, otherwise we can also just play the game ourselves. So
Yeah, absolutely. And just when you're reading this case, just be thinking about what you're doing, what else you would be doing differently. So the perfect example of kind of what we went over earlier. This is a 6-year-old male. They're still having bilateral knee pain. They've had, a total knee replacement, and the pain has just been persistent. This patient is also having that bilateral foot pain. It's idiopathic in nature, but it's ongoing. So, from a treatment history, right, we've done the genicular block, we've done the genicular RFA. It either didn't last or didn't work at all. They've done immunofixed sympathetic blocks, NSAIDs, all the neuroleptics, gabapentin, Lyrica, Cymbalta, tried a compounding cream, and now you have the patient at 30 mme of hydrocodone 10 milligrams 3 times a day. So, if you see this patient, I want you guys to think, and feel free to, ask questions in the chat, as Dr. Wiseman and I can get to those later on after these case studies. But you can also put your answer in the chat for that matter. But, just think about what you guys are going with next, right? The question is right there. Are you choosing SCS or are you choosing DRG? Kind of like we could go back to that dermatomal map where, if a patient still has bilateral knee pain, persistent after a total knee arthroplasty, what level do you think you would hit, right? So if you go back to that chart, if you have that chart in your room, you're able to take a look at that real quick, look at your wall, and you're doing, okay, let's think about bilateral L3 DRG, or let's think about treating the feet. I kind of, when I work up a patient, I kind of, what's worse, right? What is debilitating you the most? If we could fix one thing right now, what do you want fixed? And if that answer is their knee pain, or if their answer is their foot pain, it's kind of how I go about attacking that type of pain. So the answer is DRG. So you see here, okay, so this patient underwent an L3, bilateral L3 DRG trial, okay, and then they did great from trial. They ended up with a permanent implant, and you see the top leads there, right at the top of the picture, are those bilateral L3 DRG leads. Reported 70% relief of their knee pain nearly a year and a half after their implant. And once again, that's why I talk about those expectations, because no, they're not getting 100% knee pain relief. They're still having some knee pain, but 70% is a heck of a lot better than zero. And then after that, about 5 months later, they did an L5 DRG trial, bilateral, to hit that idiopathic foot pain, and they reported 100% relief of their foot pain. And then it looks like to date, they're reporting 100% relief of their foot pain and 85% of their knee pain. So their sleep has improved. They've decreased that 30 mme, and they're able to be more active and on with their life.
Love it.
Hopefully, if you guess DRG. So here's case study number 2. Okay, so this is a 59-year-old male. So chronic kind of bilateral upper extremity pain. Already had an MRI of the cervical spine. Went to a spine surgeon. They thought it was that C5 nerve possibly. So he went and had an ACDF at C4-5. Obviously, this pain has persisted. They're reporting 7 out of 10 pain. And once again, the treatment history, they did that ACDF, did not resolve the pain. They've done NSAIDs, antidepressants, muscle relaxants, opioids, had a rhizotomy, nerve blocks. Nothing has helped the patient's pain. So for this kind of situation where it seems to be kind of all over, right? Broad pain, not so focal, right? It's not hitting one dermatome, okay? And then, from an FDA, Dr. Wiseman, correct me if I'm wrong, I believe is what is it, like T10 to S2, right? Is that FDA approval for DRG? Yeah. So
Yes.
you're not doing DRG up in the cervical spine, but let's say this was the lumbar spine. Okay, so you're having that broad pain down your legs. Your choice here is SCS. Is a successful cervical trial. So you see those 2 leads, okay, go up and sit on that cervical cord, okay, and went through a successful SCS cervical trial, okay, decreased that 7 out of 10 pain score to about 2 out of 3 with burst DR, had that permanent SCS system in place, and then 6-month follow-up, they're still reporting that great pain relief. So their depression has improved, psychological symptoms have improved. I'm sure their sleep, their activity has all improved, as that all goes hand in hand. And then you see, this is what's called percutaneous lead place. Okay, so not a paddle placement. These are two leads percutaneously placed, sitting on the spinal cord. That's what they'll have. And then it looks like we'll open this up for questions. If anybody has questions, please feel free. We want this to be very informal. Please ask your questions if you have any. We'd love to answer them.
First of all, great job on those case studies. And I think, you really touched on some amazing points there. It's challenging. These patients have dynamic pain. Thank you to Abbott for sponsoring this as well as Reactivate. We will be having another webinar while people are gathering their thoughts on September 18th, and that will be hosted by my good friends, Dr. Dennis Patterson and Dr. Greg Moore, as well as Devin Parks. So super excited for that. And if you haven't registered for that, please do. Again, sponsored by Reactivate and Abbott. Additionally, we are looking for abstracts for our PSPS annual conference, and that will win you if you win, the winning abstract will actually get 2 nights comped for their stay at the Pendry as well as a $500 travel stipend. We're also looking for grants to be presented. So if you have a grant, please don't worry. Investigator initiated research is where a lot of these things start. So this would be a really great place if you have an idea that you want to study. We also have, this is the LIT webinar. So this is for kind of people who are really interested in learning and advancing their understanding of skills and technique. This is hosted by Dr. David Lee and Dr. Alan Lin with a number of fellows that will be participating and discussing the basovertebral nerve ablation of Intercept that has been recently purchased by Boston Scientific. We also have a diversity inclusion webinar that's sponsored by Saluda and Abbott. So Abbott is so great at sponsoring so many of our stuff. We're so grateful for our partners with them and all of the companies that love to sponsor this. And that'll be in October 23rd. And then our PSPS annual conference, October 3rd through 5th at the Pendry in Newport Beach. Ryan, I'm probably going to golf at Pelican Hill with my
Let's go.
boyfriend one of those days if you want to come
All
out.
right. Real quick on PSPS out to all my fellow APPs. Okay. Thursday, I believe, uh, is the APP part of PSPS.
Yes.
So make sure you come to that if you are an APP. It's for one, it's just great to meet other APPs that are just as driven as everybody else. But it's also great information. That's headed up by Dr. David Dennis Patterson, and then we've got a ton of APP speaking. Um,
Wait, bro, I'm
is it
also
also
headed.
you? It's
Yeah, it's
also
Dennis and I together. What the heck? No, but Dennis and I have been
it's
doing this together for a couple of years, and I agree. And we really would love to get more APPs involved, not just in the conference, but also membership committee, so that we can engage more APPs with PSPS. Because you guys, like Ryan, to your point, you guys do a lot of the, down and dirty nitty-gritty work of identifying these patients. And so, having more people involved so that you guys can, be speaking at these conferences, involved with these webinars. We really want to make sure that we're reaching our widest net, and that's through word of mouth. But I'm not hurt that you forgot about me. It's okay.
sorry.
My ego's
But
only a
anyway,
little bit bruised.
make sure you attend. It'll be great. It'll be great to meet you all. And then it's just great for your patients, right? Bringing great information back to patients, and like we kind of touched on earlier, these patients, I promise, are in your practice right now. Whether it be SCS, DRG, all other procedures that we have out there that you'll learn about at PSPS, for that matter, they are in your practice right now. They need these procedures. They would benefit. They're there.
Love it. Well, it looks like we don't have any questions so far, and that's okay. We're nearing the end. Ryan, any quick clinical pearls that you'd like to share, beyond what we've talked about? Just when you're thinking about a patient, any big red flags that you're like, run out of the room, don't put a device in this person. What are some things that you would like to tell the earlier version of Ryan in practice when he's thinking about his neuromodulation patient population?
I would just say if you have questions, ask your lead APPs, right? Ask your doctors. Don't be afraid. I don't think any of your doctors, any of your lead APPs would be mad at you for taking a patient to them. Instead of just ordering that trial or ordering whatever it may be, right? Just an epidural, and a patient has a history of an infection there, or has possibly a current infection there. Ask your lead APPs, ask your docs. They want these questions, I promise, and then it'll make you much more confident when you're truly thinking the same exact thing as the doctor. We are extensions of the docs, okay? And, build that mind just like they think, and go to them with your questions. They want you asking the questions. I promise you, they would rather have you ask questions than not, and get something wrong.
Love it. Great. I mean, and it's really important, like you said, to be on the same page. And I extend that not just to, my APP team, but also the representatives that I work with, right? The messaging that I want to make sure my patients have needs to be, the same, because it's one thing, we really rely on our reps to work with us because they work so close with our patients as well. And so, if the story or the kind of idea that you share in your own practice, or the ethos behind the way you practice is different than what is communicated by the rep, it can be confusing. So I think, making sure everyone is on the same page and sharing those things together is great. I will tell you this, I am often surprised by patients who I think will not be a good candidate, and it really changes their life. And so I'm not the Oprah of STEM. I don't put a STEM in everyone, and I am meticulous about the way I practice, and it's just because I have this little boutique practice in Napa. But the truth is I think reaching out to your colleagues, talking with your collaborating physician, talking at conferences like the PSPS conference, and being a part of these webinars is a really great way to kind of continue to enhance your knowledge. So with that, Ryan, thank you
Of
for
course,
spending
thank
your
you.
Wednesday evening with me. And thank you to all of those who joined live. And thank you to all of those who take the time to watch this video that has been recorded and provided for you as well. And if you have not had the opportunity to sign up for any of the other things that I talked about, please head on over to the PSPS website. And there are links for our national conference and all of the other things that I mentioned before, including Dennis and Greg's webinar coming up in the next few weeks. So with that, I will bid you farewell and thank you so much for joining us.
Thank
Good
you.
night. Thank you.